Okay. So welcome to Healthcare for All, Washington's second Wednesday speaker series. I'm Ronnie Shure. I volunteer as president of our board of directors. And last month, we addressed some improvements in behavioral health care for youth. And tonight, we'll focus on crisis care centers, an initiative to improve behavioral health care in both adults and youth. Sarah McLaughlin will share the King County plan to implement this crisis care center initiative. So thank you for joining us tonight. Just like me, you too can volunteer with Healthcare for All Washington. And please consider doing that, either joining one of our ongoing committees or just there's an opportunity to come in as an advisor just to help with a specific project or two. So go to our website. If you look in the chat, you'll see that we're posting that website. You can find the donate button, and if you are able to donate, please do that. But you can also go navigate to our website, hit the button that says get involved, and that will give you an opportunity to help find a place in our organization, find a place in our community for these social justice efforts. And every donation does help us move closer to universal health care. We have set a goal tonight to raise $250 during this program. So if you're able, please do that. Keep watching the chat for that donate button. Also, enter any questions you may have. After Susan's presentation, we will have a question and answer session. We'll pull out the questions out from the chat and we'll have a time to do that at the end or after Susan completes her presentation. You can also click on the closed caption icon. It's at the bottom of your Zoom screen. So if you hover over the bottom of your screen, you'll see that button for closed captioning, and that can allow you to bring up the words. So thank you all for joining us, and let's go ahead and get started. So this is Susan McLaughlin. She is I've lost my screen. There we go. She's a licensed clinical psychologist, and for the past 20 years, she's really been a progressive leader in health and in healthcare and behavioral healthcare and social services. She's served as a clinician, researcher, a program evaluator, and has helped design programs as well as being an administrator. She is currently the director of King County Behavioral Health and Recovery Division. And she oversees a wide range of behavioral health services for Medicaid eligible, for low income, for immigrants and refugees, including these crisis services and several areas of mental health treatment, substance use disorder treatment, diversion, and reentry. So she has worked in several other areas before returning to King County. She was CEO of Healthier Here, which was a nonprofit collaborative to eliminate disparities throughout the county. And certainly we know that universal health care is going to require people like her and like us working on those disparities. She worked at Harborview's at the University of Washington's Harborview Medical Clinics and took a break from King County for a while, but she has returned and we're glad to see her back. And what she's going to talk about tonight is a new initiative that King County voters have approved. So before you get started, though, Susan, let me just make a brief announcement or just acknowledgement that we're meeting on the lands of the Coast Salish peoples. Our efforts to achieve healthcare for all includes all peoples of this land. So please take a minute to acknowledge the peoples and the lands where you are joining us today. And we acknowledge ancestral homelands and the traditional territories of indigenous peoples time immemorial. And as we discuss behavioral health issues tonight, the indigenous people who settled our lands, the examples include traditional healing that involves the soul, as well as a person's relationship with the land and with our history. These are efforts that healthcare providers today are integrating into their care. So our efforts to achieve healthcare for all includes the coverage for Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So let's go ahead and pull up your slides. And I guess I need to remove, maybe Ron, you could remove the spotlight from me and just leave it on Dr. McLaughlin.
Thank you for that introduction, Ronnie, and hi, everybody. It's really great to be with you here this evening. I'm excited to tell you about our Crisis Care Centers initiative. I think this is a once-in-a-lifetime opportunity. It will offer transformational, I believe, resources for our community that don't exist today to help support individuals that have both mental health and substance use treatment needs. So as Ronnie mentioned, this is a property tax levy that was approved by voters in April of 2023. Throughout 2023, the King County Executive's Office was charged with developing an implementation plan, which you can think of as kind of a high-level budget and strategy plan around how the resources will be invested to achieve the paramount purposes of the ballot measure ordinance as it was passed. That implementation plan was transmitted from the Executive's Office over to King County Council at the end of December of 2023 and is now working its way through the legislative process. Talk a little bit more about that as I get into this. But so what I'm going to do today is overview for you what that implementation plan proposes. And then at the end, I'll talk a little bit about ways you could get involved if you have interest in this area. We have done quite a bit and will continue to do throughout the life of the levy and until we can get our network of crisis care centers in place, engage communities of all types to help with making these the best, most successful centers that we can to serve the purpose that they're designed to do. So looking forward to that. I will jump in. I don't know, Ronnie, are you able to pull up the slides?
I thought I did. They're not there?
I don't see them, but I'm pinned. You might have to unpin me too. I don't know if others can see the slide deck, but I cannot see it.
So, Ron, were they showing?
I don't see the slides.
Oh, well, that's not good. Let me go back here.
I'm going to remove me from the
maybe
spotlight.
I just didn't,
and then
I didn't push the button that says share the screen.
Oh, well, yeah, there is that too. All right. Wonderful. Well, so before I get into the weeds of the crisis care centers, I just want to remind people that King County manages actually a complex system. Oh, can you go back to the previous slide?
I can, sorry.
That's okay. a complex system of behavioral health services that treats individuals with both mental health and substance use disorders. At the Behavioral Health and Recovery Division, we braid multiple local, state, and federal funding sources to develop the continuum of care, everything from federal Medicaid dollars to state general fund and block grant dollars to some of our local sources that we have, like the behavioral health sales tax and now this crisis care center levy. And that supports the continuum of prevention and early intervention services, crisis services, behavioral health treatment, both outpatient and inpatient, and a variety of recovery support services. So the crisis care centers will be connected to this continuum of care, and they'll be part of that larger system. But I also want to just make sure, level set expectations. The crisis care center levy and what we're trying to do with the levy is not going to fix all of the problems with the behavioral health system. And we have to be cautious. We can't try to do too much with a limited resource, or we run the risk of not accomplishing the paramount goals. So you will see that this is scoped very carefully and intentionally to achieve the goals that it's set out to do. It's set in a system, and it's not going to fix the whole system. So if we move to the next slide, this is what when we get there, what a robust continuum of crisis services should look like, and what the sort of the vision is and best practice for a crisis system. It includes, all the way to the left, someone to call. And that's things like the King County's regional crisis line, the new 988 national crisis and suicide prevention line, someplace that anybody can call at any time, 24/7, to receive help. The next part of the continuum is someone to respond. This is things like mobile crisis response teams, co-responders, someone to come out into community where a person or an individual is that's in crisis and help support them and triage them to the right place. The third thing in the continuum is somewhere safe to go. And this is the biggest gap that we have right now in our behavioral health continuum, is that there is not a safe place for people to go who are in a behavioral health crisis. The options today are jail or an emergency room. And we know that neither of those are optimal places for somebody who is experiencing a behavioral health crisis. So you will hear today that the paramount purpose of this levy is to create safe places for people to go in a behavioral health crisis with specialty care. And then the last part is someone to follow up, and I'll talk about that when we talk about the post-crisis stabilization. Next slide. So there was thousands of individuals involved with the development of the crisis care center implementation plan. The proposed plan was informed by people with both experiential and technical expertise. So we had significant community input, as you can see, through key informant interviews, meetings. We did over 20 site and field visits to similar facilities across the country. And this implementation plan and the design of the crisis care centers really incorporates best practices that are informed by research, subject matter expertise, and these national and regional site visits that we did. So if you go to the next slide, please. The paramount purpose of the levy and consistent with what was in the ballot measure ordinance, the proposed plan's top priority is creating safe places for people to go. So basically establishing a regional network of 5 crisis care centers. And one of those crisis care centers will be focused solely on children and youth, serving children and youth. The proposed plan will also recreate mental health residential treatment beds that our community has lost since 2018, and has a second supporting purpose to grow and strengthen our behavioral health workforce. We are in a workforce crisis, as I'm sure you are very well aware. And so there are investments to grow and strengthen that workforce. Next page. So consistent with those stated purposes, you can see that the top investment priority is creating somewhere safe for people to go. And that top left-hand corner, the yellow box, is creating and operating 5 crisis care centers. The levy offers an unprecedented opportunity to reverse the trends that exist and have existed in our state for years, which is partially funding behavioral health facilities, which is a main contributing factor to facility closure over our region, because the rates for operation and the capital money available to build things is never enough to cover the actual cost. So that is very unique about this crisis care center levy, is it is going to, it will fully support the cost of building and operating the crisis care centers. Next slide, please. So let's talk a little bit about what a crisis care center is. As I mentioned, there will be a network of 5 crisis care centers. All of the crisis care centers will have and offer the same components. So I'm going to start in the middle of this slide. If you look at the 3 blue boxes in the middle, and this is sort of drawn at the perspective of an individual who is in crisis, kind of the person in the yellow shirt at the top. Every crisis care center will offer a 24/7 behavioral health urgent care walk-in clinic. That means anybody, anytime, 24/7 a week can walk into a behavioral health urgent care clinic and get immediate access to mental health and substance use disorder treatment specialists, from peer supports all the way up to psychiatrists and advanced practice practitioners. So think about it like your medical urgent care, similar to the medical urgent care, where you can walk in, get your needs met. It might be a prescription refill or some crisis planning or whatnot. For some individuals, that will be enough, and they will leave the urgent care facility and go back to their community and their residents. For some people, that level of care might not be enough, and they need some additional care. Those individuals will be transitioned to the second component of every crisis care center, which is a 23-hour observation unit. This offers a little bit higher level of care, staffed with, again, mental health and substance use disorder professionals that can continue to observe an individual's behavior, continue to do more assessment and evaluation of needs, some more treatment planning, and the person has more time to kind of stabilize from their crisis. For some individuals, the level of acuity of their behavioral health needs are going to be so high that they may be, at this point, evaluated and transferred to an inpatient psychiatric setting. This could be either a voluntary or an involuntary hospitalization. And that won't happen at the crisis care center, but will be facilitated, and the transportation to the inpatient facility would be facilitated by the crisis care center. For others, they may not need an inpatient level of care, but they need continued crisis stabilization and intervention. And so the third component of every crisis care center will be a crisis stabilization unit. This crisis stabilization unit will have 16 beds where individuals can stay for up to 14 days for continued and ongoing treatment and stabilization and setting up, outpatient services and so forth. So again, all 5 of the crisis care centers will have all 3 of those components. You will also notice that it will be a first responder drop-off component at every crisis care center. There will be the ability for first responders. So think about fire, EMS, law enforcement, mobile crisis teams. We'll have an automatic drop-off at there will be a special drop-off point at the 23-hour observation unit for first responders, so they can drop people quickly and go back into the field to do what they do best. So that's available as well. And then you can see that all of those 3 components have orange arrows pointing to post-crisis follow-up. So every crisis care center will also have post-crisis follow-up care available to individuals who are served at the Crisis Care Center. This will include providers with expertise in culturally and linguistically appropriate services, and can stay involved with an individual for multiple weeks after their crisis care center visit to make sure that they get appropriately linked with a warm handoff to the services that they need to support and maintain in the community. And then I'll just call your attention to the bottom left-hand corner. I mentioned that one of the 5 crisis care centers will focus specifically on youth under the age of 18. The Youth Crisis Care Center will also offer all of the same components. It will have a little bit of a different structure because, as I'm sure you're aware, the needs of children and youth vary greatly developmentally. And so there will be different structures to manage all age groups under the age of 18. I will also say that a child or youth can be brought to any of the 5 urgent care clinics. And then if they need the higher level of care, transportation will be offered to get the youth to the appropriate youth facility for that 23-hour observation or crisis stabilization, so that we aren't mixing children and youth together. I mean, not children and youth, adults and youth in the same facilities, obviously. So that is the Crisis Care Center model. If we move to the next slide. A little bit about the timeline here. So we will be conducting a competitive procurement process to select operators for each of the 5 crisis care centers. I mentioned that the implementation plan is still working its way through the legislative process, so we don't have authority to spend any of the money until the implementation plan is approved, but we are planning to do potentially up to 3 rounds of procurement, with the first one happening in 2024, this year. So we're anticipating the first request for proposals will come out in late July or August of this year. In that procurement round, we will select up to 3 operators for the crisis care centers. We will then do a second procurement round in 2025 to select up to all 5 of the centers. And if we, for whatever reason, haven't identified an operator for all 5 of them, we have allowed for a third procurement to happen in 2016 if that's needed. We're hoping to have all 5 identified by 2025, because if they need to be built from the ground up, if that's part of the model, obviously construction takes quite a bit of time. Our goal is to have the first crisis care center open no later than 2026. And then you can see 2 more opening in 2027, up to 2 more, and so forth, until with the goal of having all 5 open and fully operating by no later than 2030. Next slide. So 2026, even though it's right around the corner, seems very, very far away if you are in a behavioral health crisis and need help today. And so while we are waiting for the crisis care centers to come online and operate, we are proposing in the implementation plan some early investments that will start this year as soon as the implementation plan is approved, to help address and respond to some of the crises that's going on. Those early investments include expanding our mobile crisis services for both adults and youth. We have a couple of strategies focused on the opioid overdose crisis, including expanding access to opioid overdose reversal medications like Narcan, naloxone, and some capital facility to expand substance use treatment services. We also are already working towards investments in bringing back residential treatment facility capacity and beds. So we have some initial investments to preserve the beds that we have on those facilities. And then over the next 4 years, we'll be building and adding new capacity. And then the investments in the behavioral health workforce will also start early. I'll talk a little bit more about those in a minute. Next slide, please. Okay, so the ballot measure ordinance for the levy defined 4 crisis response zones in King County, which are detailed out on this map right here. You can see there's a north crisis response zone, east, central, and then South King County. There will be at least 1 crisis care center in each crisis response zone. And then the 5th one, the youth one, will be we don't know where that will be. It'll be driven by kind of need and siting and so forth. But there will be at least 1 in each zone. And this is to ensure geographic disbursement and easier access. So if you live in Federal Way, you don't have to drive all the way up to Shoreline to get to a crisis care center. You will have one within your crisis response zone. Next slide. Little bit about the siting process is probably one of the biggest challenges that we'll face in bringing these online. People need, as I said, a better place to go than jails and emergency rooms. And so our paramount purpose is to create opportunities for people to have a safe place to go. The siting of these crisis care centers is going to take partnerships. And the plan proposes a process that ensures the local jurisdictions will be central in the decision-making at multiple points throughout the process. So local jurisdictions will have the opportunity to form partnerships with behavioral health organizations, the operators of these, and will also drive the siting decisions through their zoning and permitting processes. The county will procure and do the direct contracting with the crisis care center operators, and we will prefer proposals that can demonstrate local jurisdiction support. So this is just to guard against, putting a crisis care center in a city that doesn't want it there, and fighting against some of the NIMBY that comes up, so that it is really a collaborative process to support this. And then finally, the state is responsible for licensing the crisis care centers before services can be delivered. So you can see it's going to require partnerships at every level. Next slide, please. The proposed plan includes crisis care center site requirements. These requirements are in place and intended to ensure that the sites are both viable, so they're of sufficient size, they can meet zoning and licensing requirements, and also accessible. So we're looking for sites that have meaningful transportation access, for example, and meet accessibility criteria. Next slide. The proposed plan also includes crisis care center public interest requirements. The purpose of these requirements is to align the crisis care centers with King County's environmental sustainability and equity priorities, and also to ensure that the levy creates long-term crisis care access for King County residents. So we will have things in place like a 50-year minimum use. So that means that site and that building will be used for a crisis care center for 50 years, leased facility restrictions, and so forth. Next slide. And then the behavioral health workforce investment. So again, I mentioned that this is really important. It takes people to treat people, and we have a behavioral health workforce crisis right now. So there are significant investments that we will be making that are proposed through the implementation plan that include resources to train workers through things like apprenticeship programs, resources to create hundreds of new jobs in our community that can offer competitive wages and benefits, and also investments that will create a more representative workforce. Next slide, please. I just have a couple more. There is no quality without equity, and there is no equity without quality. We really believe in this statement, and the implementation plan for the crisis care centers proposes a framework to center equity in the development of the crisis care centers and the other components of the levy, as well as ensure and increase access to culturally and linguistically appropriate services. Next slide. And none of this could be done without the accountability piece. So the implementation plan also proposes an evaluation and performance measurement strategy and principles that include transparent and community informed, person-centered, continuous improvement, and centering equity in the work that we do. Next slide. So what's next? Just a couple of things. The implementation plan, as I mentioned, requires King County Council approval. It is in the legislative process right now. The plan was referred simultaneously to both the Health and Human Services Committee and the Regional Policy Committee. We have been doing briefings and responding to questions from both of those committees. It is scheduled to be approved by the Regional Policy Committee at their April 19th. They're having a special meeting for that. And then we are looking at probably a mid-May approval, final approval from council, assuming all goes as planned. That, date could move, but that's what we're hearing right now. Once it's approved, then we can start, not that we're not already, we're actually actively working on implementation right now, but we don't have the authority to spend any of the resources, so we can't do that. But as soon as it's approved, we'll get that spending authority. We will start making investments in those early strategies that I mentioned. We're working on the request for proposals right now for the competitive procurement process, and that will go out, as I mentioned, probably late July or August. And then we have a procurement on the streets right now for current mental health residential treatment providers, and then we'll be doing another procurement later this year for adding the residential treatment beds. And then we have ongoing community engagement. So if you go, I think the next slide is how to get involved slide. Yes, so we have monthly briefings. There's on Tuesdays, there's one during the day and one in the evening to accommodate people's schedules where you can ask questions and give input. We also have a community engagement manager who is working on engagement with the community and to keep that line open. These are all the different ways that you can get input, ask questions, register for updates, and so forth. Get on our newsletter. We put out a newsletter regularly to give updates on the status of the crisis care center work, and we have a website that is kept live at all times too. So there are many ways to get engaged, and we continue to want to hear from residents of King County so that we can really make these the best centers possible. Next slide. I think that's pretty much it. I think the last slide, questions. Yeah. And then there might be a resource slide in here if you need it. But with that, I will stop. I know there's a lot of information, but yeah, there's our behavioral health resources. So we'll make sure you get the slide deck so that if you have a loved one or you yourself need help, these are just some resources and places to call right now. Ronnie, you're on mute if you're talking.
Wonderful. So thank you, Susan. I see Dave's hands raised. If you can put your question into chat or just hold on for a few minutes. We're going to give Peter Lucas, one of our board members, a chance to share some a short fundraising pitch. But thanks, Susan, for sharing that information and getting us started to think about such a critical, important issue. So don't go away, but I'm going to hide you for a minute and bring on Peter, who has been adding information or adding a link in the chat. But while you're there, please add your questions into the chat, and we will get back to those questions, and we'll start that in just a few minutes. So, Peter?
Okay, well, thank you, Susan, for your very excellent presentation. And this sort of hits home for me. I'm a psychiatrist who has put in a lot of hours working in emergency rooms. I can attest to the shortcomings of treating mental health crises in those settings and can appreciate the value of the proposed crisis centers and other services you were discussing tonight. So thanks for doing all that work. Now, over the past few years, our organization, Healthcare for All, has chalked up many legislative victories in Olympia. We were very active in the last few sessions, and many of the progressive bills we supported and lobbied for were passed. So we're very happy about that. And if you want to find out what we did or what we were involved with, click on the legislative tab on our website. Now, to maintain our momentum, it is vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their families, friends, and most importantly, those in power in Olympia. And we achieve those goals through the hard work of our lobbyist, Lonnie Johns Brown, and many volunteers who also go and testify. In addition, we employ a communications specialist and are active on social media, conduct monthly webinars, such as tonight's excellent presentation, and have meetings with civic groups. We also host other events. Now, this doesn't come for free. Financial support of our staff, including Lonnie, as well as our other activities and obligations, all require funds, which is why we are asking you to donate tonight. And our goal tonight is $250. Please go to the links I've been posting in the chat or on our website, or go to our website and click on the donate button. And you can make a one-time donation tonight, but we would especially appreciate it if you could make monthly recurring donations to support us throughout the year. So please donate so we can spread the word and bring about universal, publicly financed healthcare in Washington. And we feel we're making real progress, but there is much to be done, and you can help. Thank you so much.
Well, thank you, Peter. And I hope you will also give us a hand in monitoring the chat. Make sure thank you for adding the link to make it easy for people to go there. So thank you, thank you, thank you. So Susan, again, thank you so much for sharing that information, pulling the work together that King County has been doing. It's there are a lot of possible places that we can create these services. It's important to choose the right ones. So I guess one question I had is how much will King County Council be called on to make these decisions, or will you and your agency be given the power to make most of these decisions, or what's the role with the county, I guess? What do you expect? And the reason I'm asking that is, what can we do in interacting? We certainly have some very strong healthcare champions in our county council, include people who have been instrumental in getting our organizations, our health advocacy organizations started. So I'm thinking it will be a friendly place, but let us know how we can interact with county council to support you.
Yeah, thank you for that. So the King County Council sets policy, and the executive branch implements and operationalizes that policy. So right now, the implementation plan is that high level kind of strategic budget planning and policy document. It needs to be approved before we can move forward. So that through the legislative process, there may be different kinds of amendments that are introduced to the implementation plan, or changes that council wants to make. I mean, I think that for us, that we want to make sure that we don't try to do too much. I said this from the outset with this funding, because then we run the risk of not achieving the paramount goals. When you start to spread money too thin and try to do a lot of different things, then we will continue to perpetuate what has happened historically, which is not having enough funding to build and operate the crisis care centers, which we want to make sure that we do. In terms of involvement, I mean, these are public hearings. The council meetings have public comment periods, and so there's ways to share your thoughts on the implementation plan and the crisis care centers through that process. Once it is approved, we will be responsible for making it all happen and implementing it. So it's just really the process of the implementation plan getting approved.
So one thing we can do is share the resources or the locations you shared with us in one of those last slides to let people know how to get in to the process. So the first question is, will patients be charged? Will they have insurance info required? How about universal health care for everyone?
How about that?
Problem.
Yes. So thank you, Deborah, for asking this question. I apologize. I actually should have stated it in my presentation. So nobody will be charged for access to the crisis care centers or the services that they are provided there. That we will collect insurance information if they have insurance, but we will cover any cost share, and we will be responsible for billing insurance. That is part of what's really unique about this levy. And what we're able to do, which is cover the cost of care for anybody, regardless of their insurance status. So the budget modeling for the crisis care centers makes assumptions about how much Medicaid we might be able to draw down, how much commercial insurance money. Actually, we zeroed out the commercial insurance is an interesting thing. It's new. The state just recently actually passed legislation requiring commercial insurance to pay for crisis services. Up until last year, well, it hasn't even implemented yet. We're working on implementation right now, but up until now, people with commercial insurance didn't cover crisis services, so it was all on the backs of people. So with the crisis care center levy, people will be covered regardless of insurance or ability to pay. There will be no cost charged directly to individuals.
Thank you. Thank you. So you have made several connections with homelessness, and I guess that's the next question is, what about the providers that are reaching out to the homeless now? Are those people on your priority lists, or are your possible vendors for these services? Are there new people?
Yeah, well, so I think that's kind of two questions in one. So let me answer the operator question, which is we anticipate there will be a mix of both current behavioral health, local behavioral health providers, and there are some national providers that do this specific kind of work in other states that have expressed interest. We did a request for information back in the fall just to identify jurisdictions and operators who are interested. It wasn't required that anybody complete it, so we don't even know if we got the whole pool of people that might be interested in operating one, but we expect it will be kind of a mix of both current behavioral health providers in King County, but also some of these national companies. In terms of the connection to homelessness and homeless providers, I mean, one of the things that we will be doing is we cite the crisis care centers because they're in crisis response zones, is really working with the community of people and providers around those and within those crisis response zones to network and get folks involved. And certainly the crisis care centers will be a resource for homeless outreach workers and homeless providers to send somebody and help get somebody there if they're in a crisis. There will also be work on the other side at the crisis care center and through the post-crisis follow-up care teams to get people into housing that are unhoused when they come into the crisis care. We can't solve the housing issue, so that's going to be a barrier, right? There's still going to be people that leave a crisis care center that may not have a home to go to or an appropriate living situation, but we will be working with providers to help get people housed as quickly as possible and as safely as possible.
One of the Harborview providers, Nancy Connolly, spoke with us about providing care to the homeless, and said, you know, housing is just a critical part of that. And I know one of our big supporters, Nicole Macri, who not just a legislative supporter, but works with the Downtown Emergency Services Center, is at a meeting right now back on the East Coast on housing first. So that shows how much those kind of facilities are including that. So
We have also, well, in our department has the Housing and Community Development Division, and Health Through Housing initiative right now that is you know, working endlessly to stand up and build developments for affordable housing and permanent supportive housing for people with behavioral health.
And so the next question is about the observation unit being voluntary, people walking in voluntarily, although they will be brought in. You know, you have a choice. Where do you want us to take you? Do you want us to take you to the jail or emergency room, or how about an observation unit? And so we are certainly trying to push those alternatives. So the question is, assuming that the observation unit is voluntary, what does involuntary detention mean? And certainly, I know there's a process for that. Could you touch on where people go and where that process would lead?
Absolutely. So so generally speaking, the entirety of the crisis care centers are voluntary, from the walk-in to the 23-hour observation, and including the crisis stabilization units. And our goal and our value will be to serve people in the least restrictive means possible. One of the things that I hope will allow for that more is the design of the crisis care centers will be incredibly therapeutic and a welcoming environment with different kinds of safe places for people to be, to calm down and de-escalate, so that it doesn't reach the point of needing involuntary commitment, although we know sometimes people are really unable to manage themselves and are danger to self, or so gravely disabled that they need that. So the exception to all of that is if upon assessment, the individual is determined to meet criteria, the designated crisis responders would be called out to do the evaluation. They are the only ones that can legally commit somebody, and then a person might be held for some amount of time at the crisis care center on an involuntary hold until a bed opens up at an evaluation and treatment facility. So that is the only time that somebody would be held involuntarily at the crisis care center. Otherwise, it's all voluntary. Now, the other thing is, Ronnie, I mean, I think you named it, with law enforcement, first responder, drop off, you don't have control over what's going on, you know, what happens in the field and what people are told, but there are legal circumstances, and law enforcement does have the legal authority to bring somebody to involuntarily to a facility if they think that they need that level of care. The facility would then still do the evaluation and determine if they need to be held on an involuntary commitment or not. So if the facility determined that wasn't necessary, then the person would be released, and you know, the hold would be gone. But yeah.
And there are protections for involuntary treatment. There is a legal process, and
That's right.
And I remember at Harborview, I don't know if this is true with other facilities as well, but there was a place for hearings, and a judge would come in to do that. And so the next question, David McClanahan, being the kind, thoughtful person that he is, really comments how well this plan seems to be thought out. So he appreciating you, and he asked about potential organizations that could be crisis centers, and I think you've mentioned that in passing, but could you, is there anyone specific you want to call out?
So I would just reiterate that there are definitely behavioral health providers in our region that could do this work and may be interested. And also there's these national organizations that do this work in other states. I can just say that there is a similar facility that is going to be opening up this summer in Kirkland that is being operated by an organization called Connections Health. They're a national, they operate crisis care centers in Arizona. But yeah, we'll do a competitive procurement process and select the best operators that we can to run these. I will say also the implementation plan, this is just an important side note, is that the implementation plan recommends that a single operator operate no more than 3 of the 5 crisis care centers, and that's to protect the system from, if something were to happen to that operator, they went out of business, that the whole system wouldn't collapse. So there are some limits on how many a single operator can operate.
And the next question really is a reflection of what you just said, which is what missteps have we seen in the past? So using a variety of different, or only having one provider in each center, or doing one center is a pitfall that we ran into in the past.
That's right.
Other things that you've learned that have been passed on from previous implementation attempts?
Yeah, I mean, I
Or
think
that
obviously
considers
we've
are
never tried
successful?
something like this before, but definitely lessons to be learned. I think I've said this a little bit, but siting will be a big issue. And so the implementation plan proposes a very collaborative process that involves jurisdictions in being part of helping to decide the sites and the operators, and having some say in that. And that is really important to coupled with the community engagement. So we'll be teaming with local jurisdictions around community engagement, so we don't run into some of the NIMBY issues that we've seen with trying to site affordable housing buildings. And we had a big issue when we tried to site a sobering center several years ago with community backlash. And so really having that collaborative approach, that will be a challenge. And cost escalations is another huge risk. And so really how we do that contracting and getting really tight on that, and making sure, that we're, it'll be the operators, but controlling for delays and stuff so that we don't run into not having enough budget. And then the other shortfall that I think we've mitigated, and this is really unique, is we actually have funded the full cost of care. So as long as we don't have, ginormous construction escalations, excuse me, or something, that is really important to make this successful. We can fund these at the level that is needed to actually make them work. So we're excited about that. The workforce is the other risk. That's why you'll see significant investment in the workforce. Takes people to treat people. If we can't staff these crisis care centers to full capacity, we won't have the full capacity that we need.
So I think it's time to wrap some things up. There are a couple of more questions that we will certainly ask you to take a peek at before you leave us, and maybe share that, and we could share that information online. But thanks for your presentation, your clarity. I hope we can play a valuable role in supporting this implementation. Coming up with a plan is one thing, but actually making it happen is so important. So you have a hard road ahead of you. Please, reach out to us, and we would love to get advocates involved in making sure that happens. So thank you for your work. Thank you very much.
Thank you. Thank you all.
And so I also, not thank you so much, Susan, but also thank people that working behind the screens. The connection to bring you in here went through Downtown Emergency Service Center staff, Jim Hoffenbeck helped connect the two of us and making tonight's event happen. So thanks to Jim, to Ron Lovell, to Rich Legoo, to Peter Lucas, who helped, and our communication team that reaches out and promotes these events and gets people here. So thanks to Marcia and Sydney and Ron and Connie and John and Cello and D.W. Clark, who works in the background but really helps make that outreach possible, or that communication possible. But most of all, I thank each of you for joining us, for taking the time to look into these issues and to raise our awareness. It's so important. It is democracy at work, and it is a participatory sport. So thanks for joining us. And I'd like to invite you to join us next month. The second Wednesday of May is the May the 8th. We have the president of Maryland's Healthcare for All organization. We'll be talking about transforming public will into political power. Vinnie DeMarco has been active in a number of social justice issues, from gun control to smoking programs or regulations in Maryland, and has been involved in Healthcare for All steps. In fact, Vinnie is joining us in Seattle in June to talk about our Prescription Drug Affordability Board and to help us in supporting that. But Vinnie will talk about transforming public will into political power. So last month, I gave you an assignment to read a book, to look at Congressman Adam Smith's book about mental health crises, Lost and Broken. I don't know if many of you read that book, but I've got a new assignment, and it's about there is a book about the issues or the strength that political that advocates can bring to that political process. So this month's book is called The DeMarco Factory, the DeMarco Factor, and it's a book written about Vinnie's involvement in Maryland in the activities there. So that's your assignment. If you didn't read the book by Congressman Smith, please take some time to watch the video that we sent out earlier this week, where he shared a summary of that book. And look at some of the quotes that have come out of the past few years as he's reflected back on that journey. I think that's another politician that we can count on to make that happen. So thank you, everyone, for joining us tonight, and have a great weekend. And thank you again, Dr. McLaughlin. Good night.